right, so we're going to go ahead and start our last session. And this is going to be moderated by Stephanie Perella and Charlie Lee, who form the foundation of our pulmonary vascular program. And I think it's always important that as pulmonary vascular providers, it's not all just pulmonary hypertension, and that we are really supposed to be seeing all aspects of pulmonary vascular disease. So this last session is going to focus on pulmonary non-hypertensive vascular pathology. And I'll hand it off to you guys.
All right. Is this on? Turn it on? Give me this one. I don't use microphones very often. All right, good afternoon. We're going to start this last session off with Dr. Sasha Wong. She is a pulmonary and critical care physician at MGH with a focus in pulmonary vascular disease and also intensive care medicine. She is the associate medical director of the MICU at MGH as well, and she's going to be speaking to us about pulmonary AVMs.
No, I just have just notes. Thanks. Thank you. So the talk that I was assigned was actually pulmonary AVMs without HHT, but it is increasingly quite difficult to talk about pulmonary AVMs and not talk about HHT, so I will do my best to kind of reference when I'm talking about HHT patients or non-HHT patients. These are my disclosures. So the goals for today are to talk about the epidemiology and the etiology of pulmonary AVMs, how they manifest in our patients and how we diagnose them, complications associated with pulmonary AVMs, and then treatment. So the causes of pulmonary AVMs, so hereditary hemorrhagic telangiectasia, or HHT, is by far and away the most common cause of pulmonary AVMs. And this syndrome is really based off of a clinical diagnosis. You do not need to have genetic abnormalities or genetic testing to meet criteria. And there's 4 Curacao criteria, which include epistaxis, mucocutaneous telangiectasias, visceral AVMs, and a family history and a first-degree relative. And if you have 3 or more of these criteria, you have definite HHT and meet the clinical criteria for diagnosis. Other causes of pulmonary AVMs or right to left shunting include hepatopulmonary syndrome and cirrhosis, although as we know, the pathology of this is different than an actual AVM formation. Other things that have been reported in the literature as potential causes of pulmonary AVMs that are not HHT associated include schistosomiasis, mitral valve stenosis, a history of chest wall trauma, metastatic thyroid cancer, congenital heart disease, status post-surgical interventions, actino, Fanconi syndrome, and then idiopathic, although these need to be taken with some caution as a lot of these are kind of in the case report, single report kind of level, and so they just may be spurious associations. The epidemiology for non-HHT associated AVMs is that they're quite rare. There are several kind of case series in one series of 15,000 consecutive autopsies. There were 3 pulmonary AVMs identified. In the era of screening CTs, it was maybe a little bit more common where there was 1 per 2,600 CT scans in a study of 21,000 CT scans. These non-HHT associated pulmonary AVMs are slightly more common among women. They are usually solitary and they tend to be lower lobe predominant. And in a series of 77 patients who did not meet the Curacao criteria for HHT and had an AVM, so presumably non-HHT associated, close to 20% of those patients had neurologic complications, which we'll talk about in a little bit. So these AVMs are still quite relevant for these patients. Between 80 to 90% of our pulmonary AVMs are associated with HHT, and of patients with HHT, somewhere between 30 to 50% of them will have pulmonary AVMs. And in those cases, it's more evenly distributed by sex.
Here's what I found.
Sorry. More evenly distributed throughout the lungs and more commonly multiple. In terms of the pathology of these pulmonary AVMs, so they're made up of 3 components. There's the vascular aneurysmal sac, there's the feeding artery or arteries, and the draining vein or veins. And most of these are simple. AVMs, which I'll talk about in a second. And the aneurysmal sac itself is thin-walled. It's lined with endothelium, and it has very scant kind of surrounding tissue and a connective tissue stroma that does not interface with the associated lung, hence kind of the potentially associated hypoxemia and shunting that we see. And these vascular channels increase over time, particularly in patients with HHT, and they can increase acutely during pregnancy, which we'll talk about as well. A simple pulmonary AVM has a single arterial feeder and a single draining vein, whereas the more complex ones have multiple segmental feeders and draining veins, and can be slightly more challenging to treat. I'm not going to spend too much time on this because this is a room full of people who know a lot more about genetics than I do, and for fear of talking about SMAD proteins, a la our last session. But the majority of pulmonary AVMs, like I said, are associated with HHT and are inherited in an autosomal dominant fashion. And about 85% of HHT patients will have a mutation in either ENG, ACVRL1, or SMAD4, which are all genes that are important in the TGF-beta pathway, and which regulate angiogenesis and vascular remodeling. And SMAD4 was next to the other SMADs that we talked about during the last session, so obviously relevant. In terms of screening and diagnosis, so obviously you are not going to screen idiopathic AVMs because you don't know who's going to have them, but at least in HHT, screening for pulmonary AVMs is recommended every 5 years for the lifetime of a patient with HHT. And screening is recommended as a starting point with agitated saline echocardiography. And the sensitivity of this is quite good. And the echoes are considered positive if there is late bubbles, typically sometime after 3 to 5 beats, although for those of us that see patients with HHT, we will see some very early grade shunting in these patients with extensive pulmonary AVMs, and they don't have a PFO. It's all through the pulmonary vasculature. And essentially grade 0 shunting is no shunt, grade 1 is less than 30 bubbles, grade 2 is 30 to 100 bubbles, and grade 3 shunting is greater than 100 bubbles that appear on the left side of the heart. And so, that's obviously kind of the screening algorithm for patients with HHT. If there's a AVM suspicion for some other reason, or your patient has HHT or is high risk for HHT, you're going to obviously assess their oxygen saturation and assess them clinically. And then you'll obtain this contrast enhanced echocardiography and see if they have right to left shunting. If it's normal, the sensitivity, like I said, is quite good, and they don't have a pulmonary AVM. If it is abnormal, and we'll talk about the nuances, but if it's abnormal, you should consider getting a CT scan. And if it's normal, but you have a positive bubble study, the suspicion is they probably have microscopic pulmonary AVMs in the right patient. And if you get a CT scan and it is diagnostic for a pulmonary AVM, you kind of go down the pathway of treating that. And the reason that echo is a particularly useful tool is that the degree of shunting does predict some of our complications. So cerebral and CNS complications related to pulmonary AVMs are obviously potentially quite devastating. And the higher grade shunting, right to left shunting you have on your echocardiogram, the more likely you are to develop some sort of cerebral manifestation. So just kind of talking generally about the clinical manifestations of pulmonary AVMs. For the vast majority of people, they have no specific symptoms of pulmonary AVMs. They're found incidentally. When patients do have symptoms, they can be varied, including dyspnea, hemoptysis, hemothorax, hypoxemia-related issues. Sometimes you can hear a pulmonary bruit on exam, the CNS complications, and then the pregnancy-specific concerns. But obviously, some of these phenomena associated with right to left shunting can increase your hemoglobin if you're chronically hypoxemic, can increase your cardiac output, et cetera. In terms of respiratory symptoms, this is a table from a group of patients who do have HHT, but in 126 of these patients, about half of them actually did report some degree of dyspnea. Much rarer, but up to 12% in this series had hemoptysis at some point, and then many of them, up to 20%, a little more than 20%, were actually clubbed. So hypoxemia, if present, is commonly asymptomatic, and just anecdotally, so many HHT patients, some family member or the index patient themselves said, oh, I put a finger probe because my friend had a finger probe, a oximeter, and my sat was 86 when my, friend's sat was 100%. And these things just kind of get discovered that way when it's not known in a family. So a lot of times it's asymptomatic. And despite kind of the classic physiological teaching that these right to left shunts, and perhaps this is more true for hepatopulmonary syndrome, result in orthodeoxia and platypnea, in HHT patients or patients with pulmonary AVMs, they do demonstrate some orthodeoxia, but platypnea is actually quite rare. So in this study, they looked at supine and erect oxygen saturations and then kind of the associated change in heart rate. And about 30% of patients, their SAT fell by 2%, and in another 21% fell by somewhere between 1% to 2% on standing. Hemorrhage, so bleeding complications of some sort are obviously one of the other most feared complications of pulmonary AVMs. So the rupture of the aneurysmal sac can lead to hemoptysis and can lead to hemothorax. In one series of just over 143 patients who had been referred for embolization of their pulmonary AVMs, these are HHT patients, 8% of them had experienced massive pulmonary hemorrhage. In a smaller series of patients with pulmonary AVM who did not meet HHT criteria, 20 of them two smaller series of patients who did not have who did not have HHT. One had 20 patients in that series. 7 of them presented with hypoxemia or hemoptysis. And in a slightly larger series of 92 patients without HHT, about 3% of them had hemoptysis, or between 1% to 2% had hypoxemia. So pregnancy is particularly relevant in this group and in patients who have HHT, because these are young patients. And so kind of understanding what can happen to a pulmonary AVM over the course of pregnancy is important. So because of the increased blood volume associated with pregnancy, because of the associated increased cardiac output, and then some suspected hormonal changes that weaken the wall of the actual AVM aneurysmal sac, complications related to rupture are particularly of concern in these patients, and these AVMs can certainly enlarge over the course of pregnancy. There's estimated approximately 1% of risk of maternal death related to untreated pulmonary AVMs in pregnancy, and the rates of hemoptysis in one of these largest series, these are HHT patients, included a risk of about 1.1% of hemoptysis and about 2% of a hemothorax. And so these are the most recent 2020 updated international guidelines for HHT about what to do with pulmonary AVMs in patients who are pregnant. So in all HHT patients, ideally, you will screen for and treat any AVMs prior to them becoming pregnant. Obviously, that is not always what we have the luxury of doing. And so if a patient presents already pregnant and either has been screened and not treated or hasn't even been screened for a pulmonary AVM, typically we wait to do this until the second trimester with the thought that you want to avoid radiation exposure if possible during the first trimester and allow some of that increase in blood volume to take place. And not waiting until the third trimester to treat these pulmonary AVMs, because these, vascular IR procedures, the patient needs to be supine, get some conscious sedation, and the weight of the kind of gravid uterus can increase some risks of complications related to that. So sometime during the second trimester, ideally, you will evaluate for and treat any pulmonary AVMs. And then CNS complications. It's variable, but can be observed in up to 30% of patients and includes migraine headaches, includes ischemic strokes and TIAs, and then brain abscesses. And this is a nice paper that kind of showed the differences of these things with a single pulmonary AVM, which tends to be more common in non-HHT patients as opposed to multiple pulmonary AVMs. And you can see that it's fairly similar, perhaps a slightly increased signal for stroke or cerebral infarct and seizure, but otherwise kind of similar. So even if you only have one pulmonary AVM, the risk of having some CNS complication is still quite real. And this is a kind of different way to look at this depending on the grade of shunting, which is kind of similar to the table I showed before. But again, patients with grade 3 right to left shunting on their echo had up to a 21% rate of cerebral issues. So in terms of treating these pulmonary AVMs, historically, people would get surgery and have part of their lung resected if they were having issues related to a pulmonary AVM. And in the 1970s, endovascular procedures really started to become more prominent and proved to be quite successful. And currently, the guidelines tell us that any pulmonary AVM with a feeding vessel that's 3 millimeters or larger should be embolized even if the patient has no symptoms. And increasingly, even slightly smaller vessels, 2 millimeters in size, are embolized if they're technically feasible to try and prevent some of these adverse outcomes. These are the HHT 2020 HHT guidelines with regards to pulmonary AVMs in general, that we should give these patients antibiotic prophylaxis prior to procedures that have risk of bacteremia, which most classically is obviously dental procedures, although there's some debate about things like colonoscopy, whether people should be prophylaxed before that. I made my patient take that before she got a tattoo recently. When people have IVs, you should ask them to make sure that they are filtered, like we do with our patients with PFO, and then tell your patients not to scuba dive. So usually these patients get referred to vascular IR, and they undergo embolotherapy with microvascular plugs, amplats or plugs, and coils. Please don't ask me to explain the difference between all of those things. And the risk of persistence even after treatment is approximately 25%. So these treated AVMs can either recanalize, meaning that the embolic material that's placed there kind of opens up and the blood starts flowing through the same channel it was flowing through before. These patients can reperfuse, where they have some smaller vessels that now have more flow through them, and they bypass the original plug or coil, or they get some sort of systemic to pulmonary reperfusion. And so because of this, and in our HHT patients who can continue to develop pulmonary AVMs over time, some sort of both short and longer term follow-up is typically recommended for pulmonary AVMs and after they're treated. Embolization is really quite safe and really is the preferred method, and barring some sort of significant contraindication, really all of our patients should be referred for embolization if they have a large enough pulmonary AVM. The kind of more rare complications include angina, which is thought to be related to an air embolus through the right coronary artery and is typically self-limited over the course of a couple of hours. A paradoxical embolus, which is very rare and happens in less than 1% of procedures. Acute or subacute pleurisy, which is reported in 10% of patients and also typically self-resolves. And then really rare reports of kind of bizarre complications related to coil migration, hemoptysis. And then worsening pulmonary hypertension, which I think is quite relevant. Kind of, if you can imagine that if you're occluding or embolizing these low resistance passageways or vessels, that over time, if you have multiple areas where you've done this, that the kind of overall pulmonary pressures can rise, which can be obviously relevant to our patients who have both problems. So I thought I'd share a case that is very near and dear to my heart of a 32-year-old woman, and again, she has HHT, but I think it's still relevant, who had a known history of HHT, but presented to us at 30 weeks pregnant. And she had a history of known pulmonary AVMs in multiple locations, but particularly she had had previous embolization to the left upper lobe twice. And you can see some of these plugs and coils here. And she had been doing fine, and through most of her pregnancy had been fine, barring increased epistaxis. And she was admitted to an outside hospital with altered mental status and possible seizure-like activity at 30 weeks pregnant. A CTA of the chest at that time revealed a left upper lobe cavity near one of these previously placed coils. So there was a coil here, and she had this thing developing here, some likely associated bleeding or infection distally to it. You can see that there. So she was treated with a prolonged course of antibiotics, and then was discharged. And then subsequently, she had repeated admissions for hemoptysis of increasing frequency and volume. She would get this horrifying sensation of gurgling in her left chest, and then cough out copious amounts of blood. So she underwent angiography during the third trimester, which is non-ideal, and had embolization of both bronchial and pulmonary arterial supply to this area up here. And she had control of hemoptysis for all of 2 weeks, and then had subsequent recurrence in smaller volumes, but kind of stuttering, ongoing hemoptysis. And so her baby was delivered by C-section at 35 weeks, and immediately after, her hemoptysis improved significantly, as did her nosebleeds, and she felt fine. And we thought that that's where her story was going to end, but unfortunately 2 years later, she called me coughing up blood after having this gurgling sensation in her left chest. So we sent her for another CT, and you can see kind of all of these dilated airways, this big kind of cavity-like formation here with some central abnormalities. These are her old coils kind of extending through this posterior segment of the left upper lobe. And her hemoptysis was just ongoing, daily, kind of moderate volume. The overall, these kind of associated opacities here were thought to be aspirated blood, and you can see kind of these cavities or dilated airways there. And after kind of a multidisciplinary review, it was really felt that she did not have any further IR interventions available to her because everything had been embolized up there. So she was referred to thoracic surgery for evaluation, and ultimately underwent a left upper lobe segmentectomy. And the bronchoscopy prior to her surgery revealed that one of the coils had migrated into her airway with associated bleeding then. So she had part of her left upper lobe resected, and she has had complete resolution of all of those types of symptoms since then, and it's been another 2 years. So just to summarize, pulmonary AVMs are typically associated with HHT, but sporadic AVMs are more rare, usually isolated, and found incidentally most of the time. The degree of right to left shunting is relevant because it's associated with CNS complications. Pregnancy is a high-risk period, and so we should treat these patients particularly aggressively, and embolization is safe and effective for prevention of complications. Thank you.
That was great, thank you. Next up, we have Dr. Ada Stefanescu Schmidt. She is an adult congenital heart disease specialist and interventional cardiologist over at MGH. Her clinical practice and research focus on interventions to increase quality of life with patients and adults with congenital heart disease, and she'll be speaking to us about anomalous venous return.
Wonderful. Thank you very much for having me, for the invitation. Thank you for sticking around. So these are my disclosures, are not relevant to today. Perhaps most relevant is that I'm a plumber. I'm an interventional cardiologist. I'll be presenting from that perspective. And I'm also an ACHD cardiologist. In my world, this is a lot of those kinds of connections, like this is what we do all day, and this is what we get excited by, as opposed to some of the things that are most straightforward in general cardiology. So I'll talk about the anatomy of abnormal venous return, a couple of pearls about when to look for PAPVR, how to quantify shunts, and then what are some of the things that we can do about it. The anatomy of the atrial septum is complex. Things start with one big tube. The connections between the lung and the pulmonary veins start to form and come to the left atrium. Then there's a septation of the atrium. Then things resorb and come back. The point of showing this is that things are complicated, and there's many places in development where this can go wrong. Another point about this that in cardiology we're very picky about is the atrial septum is formed here, and so the atrial septal defects happen in the middle of the heart, the primum, secundum. The sinus venosus defect is really a defect. It's not an atrial septal defect. It's a defect of the wall between the pulmonary vein and the back of the atrium. When I think about how to find a shunt and when to look for one, I try to separate in my mind what are right to left shunts, where blue blood enters the systemic circulation, and what is a left to right shunt, where oxygenated blood comes the other way. So right to left shunts will usually pick up by positive bubble studies, whether they're inside the heart or outside the heart, like Dr. Wong was describing. Left to right shunts are detected by increasing saturation as we move through the right-sided chambers of the heart. And then I also try to think, well, what is going on with the patient in front of me, and what am I trying to explain? Do they have systemic desaturation? Do we think that might be due to a shunt? Do we think that might be due to a lung issue? Do they have chamber enlargement? And if so, is it the right or the left side of the heart that's enlarged? Do they have evidence of pulmonary overcirculation? Do they have pulmonary hypertension that we're trying to figure out the cause? Do they have high saturations on the right side of the heart, or are they hypotensive and shock? And we're trying to figure out very rapidly what's going on. This is a very common occurrence in our system and many other places. Someone will have a chest CT for something. It might be a non-contrast chest CT for lung cancer screening. It might be a CTP because they come into the ER with anything these days. And it says markedly enlarged central pulmonary arteries compatible with pulmonary arterial hypertension. And all of those patients get referred to Dr. Wong and colleagues, and then they usually look at them and then say, oh, but you had an echo a week ago, and your right ventricular systolic pressure looks like a reliable tracings, and it's 25, so you don't have PAH. And then they send them back to me. And so that's something to caution on. I think there is, incidentally, actually a lot of work that's being done with AI to now look at a lot of CT scans that are done for other indications, and then to actually screen and pick up the people who have the aortic dilation and may have an aortopathy, and pick up the people who have a pulmonary arterial dilation, which I'm sure we're going to hear more about later, and then figure out what pathology that they have. But this specific patient, not only did they have dilated central pulmonary arteries, but their right ventricle was also dilated. And so then we have to start to think, well, where is this extra volume coming from? And these are all my little friends where possible volume can come in. It can be a left to right shunt, where red blood is coming back to the circulation on the right side of the heart, like partial anomalous pulmonary venous return. It can be an atrial septal defect that comes through here. It can be an inferior sinus venosus defect or an unroofed coronary sinus. Or there can be other things that cause increased volume on the right side of the heart, like regurgitation of the tricuspid valve, the pulmonic valve as well. And these are all the possible things that we have to keep in the back of our mind when we're looking for shunts. The extra things that can cause usually volume loading on the left side of the heart are things like the PDA, the left-sided SVC to pulmonary vein is something specific that we'll be talking about in a minute, and then the unroofed coronary sinus. So to focus more specifically on PAPVR, partial anomalous pulmonary venous return, that is usually something that presents sometimes in children when they're very big, but oftentimes in adults. And it's something that oftentimes will be picked up incidentally. Someone will get into a car accident and have a trauma CT, and then they'll pick up on that, or they'll have the dilated pulmonary arteries, or they'll have a positive bubble study that was done for another reason. It is a milder form of the total anomalous pulmonary venous return. The patients with TAPVR present in the neonatal time or in infancy. That's a very severe defect, that very severe cyanosis. And this is an example of what it might look like. So it's usually the right upper and right middle veins that instead of going all the way behind the heart to the left atrium, they sort of stop and the connection never gets made, and they plug themselves into usually this superior vena cava. And it may or may not be associated with the sinus venosus defect, so a defect in the wall that's behind the wall of the SVC, basically, and the pulmonary veins. And from a surgeon's view, this is what it looks like when they look at. You have to sort of turn your head sideways, but this is a cannula in the SVC. The SVC comes here to connect into the right atrium, and then there's these things that go towards the lungs, which are the right upper lobe and right middle lobe veins. And this was a patient, that my surgical colleague, Dr. Bloom, operated on recently. Other things that are worth to keep in mind, persistent left superior vena cava is something that we'll oftentimes see on reports, and we usually ignore it. We're like, oh, persistent left SVC, whatever, it doesn't matter, because most of them end up going to the coronary sinus. They might cause a dilated coronary sinus, but all the coronary sinus blood goes back to the right atrium. So it's a vein on the left side of the body that brings venous blood back to the right atrium, so it's fine. The blood still gets where it needs to go. The caveat is that every once in a while they don't go to the coronary sinus. They stop somewhere else on the way. So sometimes they can stop to the pulmonary veins on the left side of the heart, so the venous return from the left lung. And then we oftentimes will more specifically term that a levoatrial cardinal vein. And that may be either a right to left shunt, meaning that the blue blood actually gets into the heart, and that can cause paradoxal emboli if someone has a small clot or they get bubbles in an IV on the left arm. That would go down the left-sided SVC into the left-sided pulmonary veins into the left atrium, and that can give a systemic emboli to the brain. Or desaturation, especially if they exercise a lot with the left arm, all the blue blood that comes back to the heart. Or the flow could go opposite. If the left atrial pressure is higher, then the left atrial pressure through the left upper pulmonary vein can actually decompress to a venous side. It's usually too small of a shunt to cause meaningful RV overload, but it's something that we have to keep in mind. This was an example of a young patient who actually presented with a brain abscess. And in looking at his intracardiac anatomy, we didn't find any intracardiac shunt that could explain this, but he had actually a left SVC that went to the left atrium directly. And when we did an injection here through his left arm, the injection was through the left IJ, and I was occluding the the left brachiocephalic vein here, we can see that there was blood that was going to his heart, and then some of the blood was also going through a bridging vein back to the regular SVC that was going into the right side of the heart. And since he had presented with an embolic phenomenon, and he was actually desaturated, just walking around, his sats would drop to the high 80s, we actually ended up plugging that. So that is an Amplatzer vascular plug that we put into this vein to now route all the venous blood flow from the left side of his neck and from his left arm through the bridging vein to the right side of his heart. And then this vein actually over time grew a little bit, and he feels a lot better. His sats normalized immediately. This was a similar anatomy, but opposite physiology. This was a gentleman that presented, this doesn't want to play, that presented with a stroke. He was in his mid-50s or so and also had a PFO. So in between the PFO and then this vein that was coming from let's see if I can freeze it, that was coming similarly connecting his left neck and left brachiocephalic to the left side of his heart. In him, the flow always seemed to be going so the red blood from the heart going upwards and then decompressing. And even had catheters in his left atrium, catheters in his left IJ, was measuring pressures. I made him cough, I made him exercise on the cath lab table. I could never reverse the shunt. So we thought that probably all of this was related to the PFO and was a big PFO. So I ended up closing the PFO, but leaving this vein, this venous connection alone, because his shunt seemed to always be in the opposite direction. So coming back in general, left to right shunts, as the audience is probably well aware with, is extra work on the right side of the heart. And depending on how much work that is and how healthy the right ventricle is at different points in life, and what is the compliance of the pulmonary vascular tree, those patients can present at very different periods in time. Sometimes in childhood, sometimes in adults. Most of the time they present in their 20s and 30s, which seems to be the time when the right ventricle has had enough period of flow. And that's when we start the RV starting to dilate and patients start to become symptomatic. But very rarely see patients in their 70s or 80s maybe who have atrial septal defects that are diagnosed or PAPVR, those get repaired and then they feel better. One point of caution for our fellows or younger audience members when you do a right heart cath, in many labs we'll say, well, we think about a step up in saturations. We start somewhere as soon as you put the sheath or the PA line in, and then we check a saturation in the pulmonary artery, and there's all these different parts where red blood can make it through, and then you can see a step up between your SVC saturation or your CVP saturation and your PA. But the problem is that oftentimes in most labs, the initial saturation that people get is in the SVC somewhere, or in the right atrium, actually. You put in the PA line to somewhere like, oh, that's the right atrium. You maybe pull back a centimeter, maybe not, and then get a saturation there, and then put the line all the way out of the PA and get a saturation there. And then you say, that's great, there's no step up. My SVC saturation was 78, and my PA saturation 78. Fantastic, we're done. But I would caution to never do that. I tell all my fellows to get their initial saturation as soon as they put the sheath in, which usually ends up being high enough in the SVC that you would be above whatever partial anomalous pulmonary venous return you would have, which usually comes here. And also, if that initial first SVC or right atrial sat that you're getting is a higher number than you'd expect, then you have to have an alarm bell that goes in the back of your mind to say, wait a minute, this is abnormally high. And we've seen many patients come to us diagnosed years later, and it could have been picked up on a right heart cath previously. So don't take a low saturation, it has to be high. And then also think about the IVC saturation. So in a patient where you may not find a difference between a high SVC sat, let's say it's 70 and their PA sat is 71, but if their IVC saturation is much lower because they've just had a big lunch or something, they're extracting a lot, and their IVC saturation, let's say, is 50, then the average between SVC and IVC would actually be quite low. Another fun point of physiology is that in most labs, the automatic formulas that we have to average the SVC and IVC saturation, if we're trying to see in general the venous return to the body, what is the saturation you want to compare to the PA saturation. On average, most people will use a formula that will overcount the SVC. So most computers that we still have, like our automated cath lab system, will use 3 times SVC plus 1 time IVC divided by 4. So they'll average, and it'll be a weighted average with way more contribution from the SVC. And that comes from the fact that the physiology of this was all explored by our pediatric cardiology colleagues to take care of babies. And babies are really cute because they have really big heads. And so it's true that in babies, a lot of blood flow comes from the head, and the SVC contribution to their general cardiac output is a lot higher. but we are more like this, and most of our contribution to our cardiac output actually comes from our IVC. So many times you have to actually do the calculation by hand, and probably a more accurate value based on MRI for adults is the SVC sat plus 2 times the IVC sat divided by 3. So IVC blood flow counts twice as much as the SVC blood flow. A couple of words of caution about QPQS measurements. So when you talk about shunts, one is, okay, where's the shunt? Let's diagnose that there is something going on. Once you've diagnosed a shunt on a right heart cath or a bubble study, you're suspicious, you've seen something on a CT scan, how meaningful is it? And one of the ways to see how meaningful it is to calculate a QPQS, so the amount of blood flow through the lungs, the amount of systemic divided by the amount of systemic blood flow. This can be done by a good transthoracic echo. The caveat is that there's a lot of places where a measurement error can be introduced. So one, it assumes that the blood flow goes through a very circular area, which the pulmonary annulus is more or less a circle, the aortic annulus is more or less a circle, but then you have by echo to take a really good picture, which for the LVOT measurements, any adult lab will be able to do this well. The RVOT dimension is a little bit harder to get, and depending on the quality images and depending on the body habitus of the patient, that might be quite inaccurate. And then we use the velocity time integral in the pulmonary artery and in the aorta, and then it depends on having a really well-aligned echo image. And as you can see, especially for the outflow tract measurements, those values are squared. So even a small change in measurement can actually make a big difference. And I encourage my colleagues when they're doing this to give us an error to say, well, I think that the RVOT measurement is between 1 and 1.2, and then if you use 1 and if you use 1.2, this is what your range of QPQS would be, because sometimes that makes a huge difference. And then we realize that we shouldn't be taking the number and just running with it. MRI tends to be a lot more accurate, but there can also be pitfalls in that. So MRI measurements have to use phase contrast imaging as a word of caution. That's something that you have to ask your radiologist to do. If you just send them for a cardiac MRI, they may not automatically do that. And then it depends also on the image quality that they get, and it depends if there's valvular regurgitation. So someone who has a lot of pulmonary regurg, a lot of AI, those measurements may not be accurate. So again, I caution you to think about that. And we've definitely seen patients where the QPQS is measured at, let's say, 1.3 to 1, but their RV is really dilated and they're really short of breath. And we're like, that doesn't quite make sense. We think that their shunt is actually bigger. Or the opposite is also true. They come to us with a QPQS of 2 to 1, but their RV looks really small and they're great and they're a marathon runner. Then again, that doesn't quite make sense. Other fun tools that we can have to think of, if someone has arterial desaturation and we think they have a right to left shunt, if you want to see if it's a right to left shunt or pulmonary shunt in the cath lab, you can try to cross over their atrial septum, get into the pulmonary veins and get a pulmonary vein sat. You can also use intracardiac echo. The 8 French intracardiac echo probes fit through the 8.5 Cordis that we usually use for a right heart cath. Or you have to upsize the sheath just a little bit. So that's something that we start to do in cases that we share with our pulmonary colleagues. If they have a question, we can answer the question in the cath lab. We do the ICE probe and then look at the atrial septum. This was a case that I had at the beginning of this year. It was a 29-year-old CrossFit athlete. She was going to CrossFit 4 or 5 times a week. She was fitter than probably all of us in the room, except for the person who was climbing Mount Everest soon. So Dr. Roxman, maybe not you. But she was trying to join the reserves. And when they listened to her, they thought that maybe they heard a murmur. And they talked to her more and said, well, I work out a lot, but I'm still slower than many of the other people in my class, even though I work out a lot more than they do, and that's a little odd. So then someone sent her for a coronary CT, thinking that she might have a coronary anomaly. But actually what they found is that she had this vein, there was a levoatrial cardinal vein, again, that was going from the pulmonary veins on the left side all the way up to her brachiocephalic vein. And it looked like it was a significant left to right shunt. And then she also had a secundum atrial septal defect that we could get a sense from based on the CT scan. Let's see if I can, it won't let me scroll all the way. And so she actually had 2 individually small left to right shunts, but put together that gave her a QPQS of 1.9 to 1, which was significant. And so that's an example of someone who is very fit and had worked very hard for a long time, but still had exercise limitation. And we discussed with her whether we should try to close them both transcatheter or do one transcatheter, close a secundum ASD transcatheter, and then leave the other shunt, and it would be less shunting and she would feel better. Eventually she ended up going to the OR to have both of them addressed. And then she was impressed to see that she was now the fastest person in her CrossFit. Like within 3 months after her surgery, she was still catching up and better than everybody else. So it's really an illustration that everybody is different. A little note about scimitar syndrome, which is a specific subtype of partial anomalous pulmonary venous return. It's specifically the one that's anomalous venous return that goes to the IVC instead of the SVC. And not only is it anatomically different in that the veins go to the lower part of the venous return, but it tends to be associated with more syndromic manifestations. Other intracardiac defects, they may have other intracardiac shunts or valvular disease. They tend to have a hypoplastic lung as well on the right side. They're more likely to have arteriopulmonary collaterals, and then to also have pulmonary hypertension. So that disease in a different bucket, it's more of a syndrome rather than just the anatomic difference. And so in general, to cap that portion of it, for partial anomalous pulmonary venous return, we have to be vigilant. If you see right ventricular dilation, PA dilation on imaging, or high SVC or RA saturation, think about it. Cross-sectional imaging is important for anatomical delineation. Look for other cardiac defects, and then send them to us in the congenital world. In general, when we think about interventions, the guideline recommendations say that surgery in a congenital heart disease center, and that part of it is extremely important. It has to be a surgeon who's done this a lot. It's a class 1 indication if there are exertional symptoms. That's class 1 because people will feel better. Otherwise, it's a class 2A. We think it'll be better. Maybe it'll avoid pulmonary hypertension development down the road, but we're not entirely sure. And they have to have something else, some proof that that shunt is actually significant. So their RVs enlarged, their QPQS is significant. We also don't want people to, we have to exclude the patients who have developed an Eisenmenger-like physiology, who have very high pulmonary vascular resistance. Or it can be done at the time of ASD closure that's indicated separately. The surgical options are the Worden procedure, which is here, where you basically take the SVC, cut it from above the pulmonary veins, and translocate it to the right atrial appendage, because the right atrial appendage is stretchy, so you can sort of stretch it out and connect it to the SVC. And then the pulmonary venous return and the SVC cuff can now all get baffled to the left atrium. That is the older surgical technique. The one that is most often used nowadays is a double patch technique, where there's a patch that's put inside the SVC over the pulmonary venous return to baffle it through a sinus venosus defect, or if there's not one, then they can make a hole in the atrial septum to make one. And then you've taken up a lot of real estate in the SVC, so then you have to put a big patch on the front of the SVC to still create enough space in the SVC for the systemic venous return. Those surgeries are difficult to do. Even amazing cardiac surgeons who don't do this all the time can do this in a suboptimal way, so this is really important to be done at a high volume congenital center, whether it's pediatric or adult. A couple of cautions about the surgical repairs. There's very higher veins, and those tend to be small. It tends to be a partial vein that comes from the right upper lobe that plug into the SVC. It'll be really hard to route that vein all the way to the heart. So we actually usually encourage the surgeons to not even try, just leave that behind. A very small additional left to right shunt is usually asymptomatic, so it's totally fine to not address that. If they make baffles and they're small, they can get occluded. And acute pulmonary venous occlusion, the audience will all know, can be very symptomatic. That can cause pulmonary infarct. If it's a more chronic, so the baffle gets slowly stenosed over time, then sometimes the bronchial collaterals can pick up the slack and decompress that part of the lung. But we've definitely seen patients who thrombose their baffles if they're too small, and then they come in with an infarct, or patients who come in with SVC narrowing, and then they have either SVC syndrome or they have exertional symptoms because of that. Even in experienced center, the Worden procedure still has about a 1% mortality. That 1 to 3% is mostly in kids. By adults, it's 1% or less than 1%, but that's still something. It's a long recovery, whatever recovery from sternotomy. And the reintervention rate long-term is still about 25% at 10 years. We don't have large adult data for that long-term, but it's probably still something within that range. And then specifically with a double patch technique, there's less obstruction issues, but there's more sinus node dysfunction issues. And as the surgeons are getting better, they know how to look for the sinus node, but it's in a different spot in everybody. And so it is really unfortunate when someone's minimally symptomatic and they come out of the OR as a young adult with a pacemaker. As I mentioned, they're easy to miss, and we've seen many cases of patients who present with their PAPVR too late. So this was a person who came to me after she'd had 2 lung surgeries for cancer, like 2 lobectomies for cancer, so many CT scans, more than 10. And finally had a well-timed contrast CT, and we could see that she had a small anomalous pulmonary venous return from the right upper lobe to the SVC. It was small, she was not symptomatic, and her QPQS by MRI was actually 1.3 or so we actually does not need intervention. So it didn't make a huge difference that it was missed for many years, but still. We did have another patient who unfortunately went to lung surgery, had an uncomplicated VATS, and then came the next day, had acute dyspnea and had infarcted a segment of his lung. And it turned out that he had a small anomalous pulmonary venous return that was missed, and then probably injured at the time of the initial surgery, and then that portion of the lung became infarcted and couldn't be rescued, and had we known previously. So it really needs to be a high degree of suspicion. And in addition to looking and see on the CT, is there anything unusual that's plugging into the SVC? The other thing that we encourage people to look for is look at the left atrium and see if there's two veins or enough of venous confluence coming into the left atrium. So there's a few patients that we pick up because you don't clearly see the veins into the SVC, but you see that the left atrium looks kind of bald, especially on the right side, and that should trigger to think about getting a better time contrast CT. And so the last little bit is to talk about the interventional options for this. This is something new in the last probably 5 years or so around the world, 5 to 10 years around the world. There's more and more experience with, instead of sending patients to surgery for partial anomalous pulmonary venous return, actually dealing with this in the cath lab. And so this technique has been well described. It's basically the insertion of a covered stent starting in the SVC to the top of the right atrium. And this covered stent will now funnel all the blue blood coming to the SVC inside the right side of the heart, which is supposed to be. And then the anomalous pulmonary veins behind it will go behind the stent through the sinus venosus into the left side of the heart, because now they can't come into the right side of the heart anymore. It's a very elegant procedure that works very well for selected anatomies. If the patient does not have a sinus venosus, then you can't do that. If the pulmonary veins come in very high or very low at an odd angle, you sometimes can't do it. But the majority of patients actually present as older kids and adults would be a candidate for this. So it's definitely worth screening them and talking to colleagues in your centers. We are extremely confident about how wonderful this is because we're doing our first one at MGH on Monday. So it's going to go great. But I've done some of those in Toronto during training. And in the right anatomy, it's a really elegant solution that avoids the car crash of a sternotomy. And this is what it looks like. So this is, after the covered stent has gone in, this is 2 overlapping stents because they need to be quite long. We're injecting into the right-sided IJ here, and all the blue blood is going to the right side of the heart, pulmonary arteries, and then have a catheter injecting into the right upper pulmonary vein to prove that it's still unobstructed and going nicely into the left side of the heart. The outcomes with this are quite good. There's 138 published patients. Sorry, I keep right-clicking here. There's 138 published patients, but the experience worldwide is probably in the 400 range, if not more, with follow-up up to 5 years and no new issues. Importantly, patients don't have the sinus node dysfunction issues that we've seen in the surgical series, but obviously we need to follow these people long-term to make sure that the stents stay open. It's a very big stent, so they should, but it's still a growing area. And then one quick word, we've talked about BMPR2. It definitely seems to be a little bit more common in some congenital populations. And the general message is that in especially pulmonary PAPVR, the shunts tend to be relatively small. It's not patients who come in with a QPQS of 3 to 1. It's usually 1.5 to 2, somewhere in that range when we think it's significant. And some of them will have a very abnormal pulmonary vasculature, and some of them will seem pretty normal. And we think that it makes sense to close them to make people feel better. But do we really affect what's going to happen to their pulmonary vasculature? And I think the question is that we don't know. I think there is, from a genetic point of view, some people are predisposed to it, and that small shunt may be a totally innocent bystander. It may be the second hit that's causing them to progress, or it may be that it's a big enough shunt. And then there are definitely syndromic associations with PAPVR and other intracardiac shunts, and also PH, that probably the same pathway that creates both of them. And so in conclusion, if you see someone with right-sided heart dilation, with pulmonary arterial dilation, look for left to right shunts. Look well on all this imaging that they've had so far. When you check an SVC saturation, make sure that's high enough and that it's not, make sure that's high enough in the body, but that the number is low. If the SVC saturation itself is a high number, then be curious. Careful CT, and then use that TE or intracardiac echo to also look at the time of other testing. For surgical repair, it has to be done at expert centers by congenital surgeons, and then now we have transcatheter therapies for people with specific anatomies. Well, thank you.
All right, so our next speaker is Phillip Joseph. and I've actually known this guy for a little bit as well. He's the assistant professor of medicine in Yale School of Medicine, associate director at the Yale Pulmonary Vascular Disease Program, completed his fellowship at Brigham Pulmonary Critical Care, and as well as a Brecht Fellowship. He has interest in management of pulmonary vascular disease, as well as invasive CPET. And, sorry, I didn't even ask you about your topic that you're going to be talking about.
Okay.
He's going to talk to us about left and right shunting and how that enhances pulmonary blood flow.
All right, good afternoon. I'm going to be wrapping it up. I know Dr. Farber's after me, but maybe I'll be some comedic talent here. And thank you, Dr. Waxman, for inviting me to Yale North, as we like to call it. I did not make that up. But I trained under the great Dr. Waxman, and I was also on the Bach service with Ada. So good to reconnect. So I will be talking about left to right shunting and enhanced pulmonary blood flow. I'm at a right heart symposium, and I will not be talking about the right heart. I have no disclosures. I remain a lowly paid academic clinician. Industry come find me. All right, so the goal is to discuss the use of invasive cardiopulmonary exercise testing in the evaluation of unexplained dyspnea and learn about non-pulmonary hypertensive exercise pathophysiology. I'll start off with a case. This is a 30-year-old female who presents with 1 year of exertional dyspnea and exercise intolerance. Her symptoms started after mild COVID, notes persistent dyspnea that continues for hours after exertional activities, fatigue that significantly worsens after strenuous physical or cognitive activity. And she has a pulse ox that reveals desaturation during exercise. She's lightheaded after exercising. She has unrefreshing sleep. She has brain fog. No resting dyspnea, no chest pain, palpitations, chest tightness. She has this diagnosis of asthma, but no symptomatic improvement with PRN albuterol. Past medical history, she was diagnosed with POTS, postural orthostatic tachycardia syndrome, with a tilt table test. Didn't really respond to Florinef or midodrine. Well-controlled asthma, as I said, a fibroadenoma of the breast, a Raynaud's phenomenon, so maybe an autoimmune phenotype, GERD, depression. She's on Symbicort, albuterol, PRN, omeprazole, famotidine. She's a software engineer, no toxic habits. Her physical exam, pretty normal, thin, Caucasian female. Blood pressure's normal. O2 sat 94% on room air, low normal. I mean, it's a little surprising to me. Otherwise, a normal exam. EKG is normal. Pulmonary function tests, no obstructive physiology. Lung volumes are normal. DLCO corrected for hemoglobin is 83% of predicted. Sorry, my PowerPoint. So within the normal range, but lower than I would think. X-ray, normal. We all are familiar with this kind of patient who comes to us. Echocardiogram, normal biventricular function. EF is 58. RV size is normal. Inadequate TR jet. Instead of the 6-minute walk test, we do something called a submaximum exercise test, which is stepping up and down on a stool with a metabolic cart and assessing gas exchange. Oh, what is this? Okay, I'll just stop then. Sorry, I didn't want to use subtitles. You should have just told me. All right, so the VE/VCO2 is normal, 30, but a little bit high. But the key points here is that by using end-tidal CO2 as a non-invasive surrogate for cardiac output, their dynamic pulmonary perfusion was 0.1, and it should go up by around 4 during exercise. So maybe suggesting there's some abnormality in the cardiopulmonary circulation. And at least by pulse oximetry, the oxygen sat went down from 94 to 89%. We can estimate pulmonary vascular capacitance using gas exchange, as end-tidal CO2 times the O2 pulse, and this has been shown to correlate well with right heart cath pulmonary vascular capacitance or compliance, and that was in the normal range. Below 400 is considered abnormal. So, like everyone, she ends up getting a right heart catheterization. Ada, I will have you know that I took this SVC sat in the high position at the sheath, and my fellow is in the back there, and she can confirm that. So the SVC is 65%, RA 64%, PA 64%, so no oximetric step up, no left to right shunt that I'm going to pick up on my right heart cath. Right atrial pressure is 10. Mean PA is 21. The wedge pressure is 10. Cardiac output is 4.1, and the pulmonary vascular resistance is 2.68 Wood units. So that's it, right? She got diagnosed with precapillary pulmonary hypertension, and then we're going to go on to treatment, aggressive treatment, like we were talking about yesterday and today, triple therapy, quadruple therapy, put her on sotatercept, send her to Dr. Waxman, drill an IO in her, in the unit, put her on Remodulin, and then put her on Orenitram, ambrisentan, tadalafil. But I'm struggling. So when I struggle, I go back to my textbooks. This was Indy Singh reading me a exercise physiology lullaby before going to bed. And I was pretending to read the book. But I go back to my Wasserman diagram and figure out where the defect is. Oxygen has to travel through the lungs, go out through the left heart to the muscle bed, get metabolized by the mitochondria, produce CO2, go through the veins, the right side of the heart, that's my only mention of the right heart today, and gets exhaled into the atmosphere. So we do something called an invasive cardiopulmonary exercise test to try to figure this out and try to figure out why a patient is dyspneic, if this will play. So there's Indy Singh there. We are placing a right heart catheter and an arterial catheter, usually in the left radial artery, continuously measuring hemodynamics and continuously measuring gas exchange with a metabolic heart. The balloon of the PA catheter is inflated every minute of exercise to get a wedge pressure. Mixed venous samples and arterial samples are drawn every minute to calculate a direct FIC cardiac output. We also can do this in the semi-recumbent position with simultaneous echo. If we want to evaluate for any aortic valve pathology, mitral valve pathology, sometimes we even do a bubble study during exercise. Most importantly, this patient's giving a thumbs up, so it's a very well-tolerated procedure. There. So what's the point of this? Point is that non-invasive exercise testing usually is good for seeing if the VO2 is down and assuming that that represents cardiovascular impairment. Looking for pulmonary mechanical limitations to exercise. If your minute ventilation divided by your maximum voluntary ventilation is greater than 0.7. Looking at the anaerobic threshold. I know there are data to look at mixed expired CO2 versus untitled CO2 ratios to try to figure out if someone has pulmonary vascular disease or heart failure or obstructive lung disease. It's pretty nonspecific. So what the invasive exercise test does is expand on that differential and looks for a central cardiac limitation using the direct FIC cardiac output to see if the peak cardiac output is less than 80% of predicted. And if it is, seeing if that patient has left heart disease, this is some controversy I'm injecting here, using upper limits of normal based on age versus pulmonary artery wedge pressure versus cardiac output slopes greater than 2. If they have pulmonary vascular disease, again, using upper limits of normal versus flow-corrected mean PAP slopes or TPG slopes. I'm not going to really mention preload failure. And then going to peripheral limitations to see if there's an impairment in peripheral oxygen utilization, suggestive of a mitochondrial myopathy or peripheral left to right shunts. So this patient went on to exercise. I did not put her on Remodulin. And her VO2 was 90% of predicted. Her cardiac output, calculated by the direct FIC method, was 115% of predicted. Her mean PAP went up to 33, but importantly, you have to correct it for the cardiac output, and the pulmonary vascular resistance was 0.9 Wood units. So I do not think this patient has any form of pulmonary vascular disease. And then one thing I wanted to point out was that the VO2 is equal to the cardiac output times the content difference. And that if you have a disconnect between your VO2 and your cardiac output, the abnormality has to lie within one of these variables. Is there impaired oxygen delivery or impaired peripheral oxygen extraction? And that's what we saw. So the mixed venous sat at rest was 68% in the upright position and went down to 41% at peak exercise, which is quite high. We know that from a lot of exercise physiology research that even in the deconditioned individual, the mixed venous sat at peak exercise should be around 25 to 30%. So this signifies that there's some abnormal oxygen extraction in the muscle bed. She was having this reported desaturation events, and she did not desaturate, so her SaO2 remained at 99%, and her AA gradient did not widen. I just put this in because we were talking about left to right shunts, and I was talking about that VO2 versus cardiac output disconnect. So you should always think about intracardiac left to right shunts. I was glad to see that that CrossFit athlete underwent repair because this was a study in New York Heart Association 1 and 2 patients, and also with QP-QS ratios less than 2 and along with greater than 2. And by closing that left to right shunt, the VO2s improved after at 6 months. So maybe suggesting that we should be closing shunts in mildly asymptomatic individuals. But I'm going to really focus on peripheral left to right shunts. So we always think about the lungs, we think about the heart, but the muscle bed is also important, and it can contribute to dyspnea. So we looked at a cohort, this was when I was a fellow with Dr. Sistrom. We looked at a cohort of patients with chronic fatigue syndrome in our invasive exercise database. About 160 patients were analyzed in a retrospective fashion, and we separated them by their exercise phenotypes based on cardiac output versus VO2 slopes. And we saw that there was a significant amount of patients with a high QC VO2 slope, and they were also, they had impaired peripheral oxygen extraction. So we had these control patients, which, caveat there, they're controls, but they're symptomatic controls with no known exercise pathophysiology. Their peak mixed venous sat was 30%. And in the high flow group, their peak mixed venous sat was around 45%, highly suggestive of peripheral left to right shunts or mitochondrial dysfunction. And we made sure to look for oximetric step-ups in our review of these cases, so no intracardiac shunts that we picked up. One of the thought processes is that this could represent abnormal innervation of peripheral AV shunts. There are studies that look at skin biopsies in patients with syndromes such as fibromyalgia, and looked at revealed abnormal innervation of these peripheral AV shunts, so bypassing the exercising muscles. So what this is showing is neuropeptide Y is a vasoconstrictor peptide. CGRP is a vasodilatory peptide. So if you have a decreased ratio, that means you have more vasodilation going to these AV shunts, and then you just have more AV shunt, peripheral AV shunt area in these biopsies. Some associated conditions, like I mentioned, we looked at a cohort of patients with ME/CFS. A lot of these patients had POTS, fibromyalgia, mast cell activation disorders. Autoimmune conditions can contribute to this, post-viral associations. And then I threw this in from the morning, but we're talking about dyspnea and PE. And I would argue that we see this a lot in the CPET lab. I'm sure Dr. Waxman sees this as well, where we have a peripheral impairment in oxygen utilization in our post-PE syndrome patients. We're all familiar with long COVID or PASC. So we also looked at this in the persistent exertional intolerance after COVID-19. This was a small study, 10 patients. We're working on publishing a follow-up to this. And the key point here is that their mixed venous sat at peak exercise was around 50%, which again, it should be around 25 to 30%, highly suggestive of peripheral left to right shunts or mitochondrial dysfunction. This is kind of just showing the same thing, which is your extraction, normal extraction should be around 80%, 75 to 80%, and this was around 50%. We also saw a hyperventilatory response. This is another key point about the utility of invasive exercise testing. So we are directly measuring PaCO2, so we can calculate dead space at rest and peak exercise. So we eliminate the possibility that the VE-VCO2 is caused by an inadequate decrement in your dead space fraction. So these patients hyperventilated. And the reason that's important is that hyperventilation can cause a leftward shift in the oxygen-hemoglobin dissociation curve, causing impaired oxygen offloading in the periphery. So this is another left-to-right shunt, peripheral left-to-right shunts that we should think about. I will be the first to say that I don't know how to treat this, and that maybe we should be targeting the mitochondria with a cocktail of high-dose vitamins. I'm sure Charlie is well-versed in maybe prescribing that, but no data to prove, or very limited data to prove any of this. So I hope I've accomplished my goals, and I think we're leaving questions, but I don't have kids, so those are my cats. Pumpkin and popcorn.
All right, so our next speaker, I don't think I need to introduce him, but it's Farber, Dr. Farber. He's been a pulmonologist since like it's been ages, more than 20 years of practice, has...
All right, how do we find this thing? All right, so for those of you who hung in here, Aaron told me to tell you that everybody gets free alcohol. But anyway, thanks for sticking around. So they wanted me to talk about pulmonary artery aneurysms, whether it's a surgical disease. And the answer is not really, we're done. Those are my disclosures. They really have nothing to do with this. So we're going to talk about three things. What is a pulmonary artery aneurysm? What things are associated with it? And what do you do with it? Okay, so it's rare. I mean, it's incredibly rare. So if you look at autopsy studies, it's about 1 in 14, 15,000 autopsies based on a study from the Mayo Clinic in which they did about 110,000 autopsies. So as any aneurysm, it's a focal dilatation of all three layers of the vessel wall, which differentiates it from a pseudoaneurysm, which doesn't involve all the layers. Okay, the main issue with this is it can cause really catastrophic stuff, okay? And this is why you need to treat it aggressively. So what are the catastrophic stuff? Well, the major one is massive hemoptysis from rupture of this aneurysm. Massive hemoptysis and basically death. Coronary artery compression, there are several cases where the things have been so big, they've actually compressed the coronary artery and actually sort of mimicked having acute coronary syndrome. Or you can dissect your pulmonary artery, also not a very good thing. So what causes it? Well, there are some things that are congenital and some things that are acquired. Okay, the congenital ones are Eisenmangers. And a whole group of also pretty uncommon connective tissue abnormalities, Marfan's, alpha-1 antitrypsin, tuberous sclerosis, and Ehlers-Danlos. Then there are abnormalities, mostly congenital, of your pulmonic valve, such as pulmonic stenosis, absent pulmonary valve syndrome, and bicuspid pulmonary valve that can cause this. More commonly, at least what we see, if you've seen any of these, are things that are either acquired. Now you can get them from chest trauma. The most common thing is a acceleration, deceleration injury into like the steering wheel or the airbag of a car or something like that. Iatrogenic from a right heart cath. Have you ever done one? Caused the pulmonary aneurysm for right heart cath? Huh? You wouldn't admit it anyway. No, no, I don't think I have. I don't think I have either. I've seen lots of caths. I don't think I've ever seen one. Okay. Infection either from syphilis, TB, or endocarditis, lung cancer, and pulmonary hypertension, especially severe, long-standing disease. And this is the only time I've actually seen one. And this woman had pulmonary hypertension with systemic pressures for many years. These are the sort of, oh, wow, I can't believe we found this diagnosis kind of causes. Autoimmune diseases and vasculitis. And they're rare, but they include Takayasu's arteritis, Behçet's, and then Hughes-Stovin, which is thought to be just a form fruste of Behçet's or a mini Behçet's, okay, in that it only affects vessels and your lungs as opposed to mucosal stuff and things like that. Hughes-Stovin is so uncommon, there are less than 50 cases reported in the literature. The pulmonary artery aneurysms, Takayasu's, are usually post-stenotic, so they don't really count in this, but they do, sort of. So the real one, acquired ones, are Behçet's and its little cousin, Hughes-Stovin. So what do these things look like? Well, this is what they look like. This is post-pulmonic valve stenosis. Obviously, the vessel after it is just enormous, okay? The Hughes-Stovin ones are interesting in that, does this thing have a little pointer on it? Huh? Oh, the mouse. Whoops. Hey, nobody said I was good at this. Okay, so this is the Hughes-Stovin with a marked dilation of the pulmonary artery. But the thing that's important is this stuff around it. So it's already leaked a little and bled a little, which is not a good harbinger, okay? And this is very common. And this other one that's amazing is, so this is a peripheral one in Hughes-Stovin. There's where the dye goes, and all this around it is already blood that has leaked out. So these are things that really are, it's almost like a powder keg. You're sitting there waiting for these things to explode, basically. Okay, and there are, at least in both Behçet's and Hughes-Stovins, there are multiple cases in the literature of people just killing or massive hemorrhage with this stuff. So what do you do for it? And the answer is nobody really knows for sure. In part because there just aren't enough of these to form any kind of consensus about what to do. The only consensus is you need to get rid of them somehow. But the somehow is clearly not well known. Okay, and in all likelihood, to be honest, will never be really well known because there just aren't enough of these around to compare different treatments and stuff like that. The options are, well, obviously the treatment depends on the etiology, the hemodynamics, and the comorbidities. Obviously, if it's from a right heart cath or something like that, you're probably going to have to fix the pulmonary vessel. If it's from lung cancer, obviously you'd like to take the lung cancer out. If it's from other things, you'd like to treat it, especially the Behçet's and Hughes-Stovin. The current treatment is really aggressive immunologic modulation to see if you can make them smaller. But in general, if they're big like the ones I showed you and they've already shown signs of leaking blood around them, you got to do something. So there's two options. One is surgical, which I was supposed to tell you is the treatment of choice or not. The treatment of choice for surgical depends on where the thing is and how big it is. So you can go all the way from an aneurysmectomy to lobectomy to bilobectomy to pneumonectomy. But as you can imagine, with all of these vessels that are abnormal, the risk of these surgical procedures are just overwhelming, okay? So there has been, just sort of like in AVMs and stuff like that, there's sort of a move away to not do surgery if you can avoid it. And currently, there's a lot of, more of these are being done with endovascular interventions, embolizations, stents, plugs, et cetera. However, as you would imagine, there are no guidelines about who should get what. But they're used more frequently because interventional radiologists have the tools and they're gonna do what they're gonna do. And what's the right one for each patient, nobody really knows. So if you sort of go by this, and I apologize because it's a lot and it's a little illegible, but basically what it comes down to, this is adapted from a paper that was in Pulmonary Circulation about 3 years ago. And it outlines sort of an algorithm, but it comes down to the same point, is a lot of it depends on where it is, how big it is, and also what your pulmonary pressures are, whether you actually have associated pulmonary hypertension or not. And you're back to the same thing. Do I surgically take this thing out, or do I try and do interventional radiology? The only case of this I've seen outside of one caused by long-standing pulmonary hypertension was in somebody with Behçet's. And we did manage to close it off with endovascular IR. Okay, so my N of 1, yeah, go endovascularly. Okay, trust me, that's not a great endorsement, one way or the other. So the bottom line is, this is rare. I mean, these are incredibly rare. I think most of us could probably go through our career and not see any of these, okay? They don't have any distinct syndromes at all. There's nothing that the patient exhibits that tells you, oh my God, I've got one of these things. The use of CT actually has resulted in probably an increase in the diagnosis of them. And again, it depends how you define how big an aneurysm actually is. And then there's no guidelines for diagnosis or management or follow-up or anything. So whatever sort of turns you on, you just sort of do. So obviously, since there's nothing and you need further investigation, which unfortunately you're not going to get because it's so uncommon, you're never going to get a large enough group of these together to do some sort of trial that's going to give you an answer. It's really just basically judgment between clinicians, IR people, and the surgeons who would take this thing out. I mean, that's really all you can do. Probably depends on the clinical status of the patient, the size of the aneurysm, the hemodynamics, and whether the thing's bled yet or not. Because if it's bled once, it's going to bleed again. That's all I got.
So I have 2 questions and a follow-up to have. I actually follow, I think now 7 patients with pulmonary artery aneurysm that I would diagnose as greater than 4 centimeters to 4.5 centimeters at the proximal main and extending out into the right and left. And they've been ruled out for any of the inflammatory disorders, did not have vasculitis, do not have syphilis or TB, and are entirely asymptomatic. And it was all incidental findings, and I just follow them. I think one question is, how long do you have to follow them for, and how frequently do you follow them for? Because obviously, with that, the only way to follow them is either by MR or by CT. And I'm not thrilled about all the radiation that will come over a lifetime. So that's one thing. For the AVMs, there's definitely a variety of AVMs. I guess my question would be is there a role for anti-angioproliferative therapy? I know we do some in HHT, but especially in the non-HHT, just thinking about some of the patients who might have connective tissue disease and even have AVMs elsewhere. And then my last question, and then I'll let you all address them, is Dr. Joseph, you made it clear the patient has a left to right shunt, and it does increase pulmonary blood flow. But you haven't answered why the patient is short of breath. So why is the patient short of breath?
You can take that one first.
My feeling is that they do not have appropriate oxygen utilization, and it's a peripheral limitation. You're talking about.
Your CaVO2 difference looked like it was pretty appropriate. And you didn't show the lactate, so I'm assuming the patient, but you did make the point that the patient doesn't have a mitochondrial disorder. So from what I can tell from your invasive CPET down there at Brigham South, is that there's enhanced pulmonary blood flow.
So you're,
Why do
maybe,
patients, and the same thing could happen with an anomalous pulmonary venous return. Why do those patients have shortness of breath if they have all this excess flow and there's no defect at the level of the mitochondria, and that change in mixed venous oxygen saturation is simply a reflection of the added red blood to the blue blood?
I think
And
what
add
you're-
to that, why are they hyperventilating? That may be more shorter, right.
yes, that can
Is that the primary part?
dyspnea.
Hyperventilation, you can use as an excuse for the high mixed venous sound.
Right.
Because it's a lot higher than it would be if it were just hyperventilation.
Correct. So I think what you're invoking when I was a fellow was increased pulmonary blood flow, maybe stimulating J receptors in the lungs. Right. And I did, there was a paper, a congenital paper, looking at ASDs and increased left to right shunting. And I don't know if you see this in the congenital heart population, where they oftentimes get diagnosed with reactive airways disease, but it's all increased pulmonary blood flow, and that goes away. The paper that I'm thinking about, I reviewed it, was after closing ASDs, their symptoms of reactive airways disease went away. So potentially could be due to increased pulmonary blood flow causing dyspnea.
Yes. That's what we also wave our hands and think.
Yeah, I mean, I think it still remains intriguing that after we do the invasive CPET, there still is hand waving, that we actually don't really know what causes some of those things, and which is the chicken and which is the egg. So before we sort of just say it's, J point, that is it a primary reason for hyperventilation? So, I'm not sure, because so many of these patients have more than one thing. So many of the other patients you speak about with, POTS, well, this one had a CVP of 10 or 11. So you can't say that that's what the case was. So that's one issue. The issue about the aneurysms. So, it's one thing when we have aneurysms that are 4.5. I had to operate on somebody with hereditary PH, treatment for 20 years, but PAs that were 9.5.
Jeez.
Right. And I'm sitting on another one evaluating it at present. We also get into the discussion. So, and many of them have some syndrome, I'm not sure, exactly what to do. The question also comes up if they have severe PH and have that degree of pulmonary artery aneurysm, whether we send them to transplant sooner.
It's the same with like Aaron's case. I mean, you have these people who show up, and the problem you have is you have to balance the risk of this thing not staying where it's supposed to or staying the same size versus doing something about it before it does that.
Right, but part of the issue, I'm going to say, the pathology of this pulmonary artery aneurysm looks like an aortic. It's a medial necrosis, and sort of, it is a weak wall, and it's going to continue.
Absolutely. And the higher the pressure, the more likely it is to not stay where it's supposed to be.
And yet you then give them medications that may increase their flow, so they can have high pressures and high flow, okay, which, certainly from the aortic side is exactly what we.
You could argue in some of these people, because some of them do in fact have pulmonary hypertension, is that get their pulmonary pressures down, at least decrease the risk, hopefully, of this thing actually breaking.
Right, but I'm giving you examples of people who are on maximal pH therapy, have been on it, and so that's where you are. Like they may be on a 80 nanograms, of Remodulin and 3 others, and a low dose of a beta blocker. And should they go for transplant?
So the problem, again, it goes back to the thing, is there just aren't enough to give you a right answer. So the best thing you can do is you sit down with surgeons, IR, and whatever, and decide to do it, or just, have a very strong diaper every day when you're worried about that. No,
Right, but Hap, the proximal ones you can't do with radiology, right? The proximal ones can only be done surgically.
No, it's hard.
I do want to point out that the group of patients I was referring to, I cathed all of them. None of them have pulmonary hypertension. They just have what I would probably just say an idiopathic pulmonary artery aneurysm.
Which is decidedly uncommon.
It's very different.
Which is even.
But if you look at the Chinese literature, they actually operate on those patients, and most of them die.
They should be on it.
So the moral behind that is don't get operated on in China. No, I mean, it's hard. I mean,
I believe.
it's sort of again, it's sort of a joint decision, also obviously involving the patient, discussing risks and benefits. There's really no good answer.
Yeah, but we're creating, we're making those things up too.
Yeah, I mean, it's surprisingly, like everything else, it's nice to have a little data.
I believe Anton had
And
his
then
question
believe it.
next.
Yeah, I have 2 questions. One to Ada, because it really depends on your radiologist how much partial aberrant pulmonary vein connections you find. Now, we have a very good thoracic radiologist nowadays, so I get referrals 10 times a year because you see them more. And then you ask them, they have some exertional dyspnea. If you ask them, they know they have something, and then the right ventricle is a bit dilated, sometimes at the age of 70. I feel not so much inclined to repair all these type of things. According to your table, I should actually do it, but it's just an abnormality, which is quite common, and they are used to it. Probably they can do better after this repairment, but they are used to it and have made their life of. So what's your opinion about that? My approach, practical.
I think it makes sense depending on how old the patient is and what they want out of life, and then how big the shunt is. I think if someone's made it to age 70 and their PA pressures are okay and their RV is still functional well and fine, it's dilated, if they have a very big shunt, then I'd be a little bit concerned about them. But if they've made it to age 70 and they've been okay, then they're probably going to continue to do fine. Unless it's someone who is very active and you think their life expectancy is going to be another 20 years and they're starting to really feel it. So I think it's very different. I think looking at a 30-year-old patient is...
And the stent placement you showed, or the device placement, that's your first choice in that case nowadays?
I think for an older person, that would be great, or for someone who's young and wants to avoid surgery. It depends on the anatomy, as always, but in someone with good anatomy, I think it's very reasonable to start with a transcatheter therapy first, because if there's something that goes on with a transcatheter therapy, then they'll go to the OR and they're going to have a surgery anyways. But if we can have a chance to avoid the surgery, then we might as well.
Now I have a patient, and he had a BMPR2 mutation and a PAH from his age, and he had also a partial aberrant pulmonary vein. And now he is 30 years of age, and his pulmonary artery is 11 centimeters, and it's growing every half a year. That is dramatic. So I never have seen, I'm quite old nowadays, but I've never seen a collapse of a pulmonary artery, but this is something I had to do something with it. Sent it to China, probably not a very good idea. I do know Stanford has replaced 5 of them, and I just want to know whether somebody in the room has an advice, because it's growing now 3-4 millimeters in 6 months. So it is, I don't know whether this is something HEP has a good idea. My surgeon wants to do placing a cast around it, and which is called the bent operation. They do it also for the aortic and to suture it down to the normal size. But I feel a little bit scared about that as well.
I would, yeah.
Yeah.
From a congenital perspective, one way, we've heard about the arteriopathy, and there's probably an arteriopathy on the PA side as well. And so in those cases, what we've sometimes done is to ask them to actually replace it with something, put a big Gore-Tex graft or something that's not going to dilate again, because if you take something that's very abnormal tissue and you make it smaller, the wall stress is going to be lower, but it might still dilate again in the future.
Okay, but then he's all, because his pulmonary arterial pressure is high, but he's very much well regulated. He's near functional class 2. So, and he's on triple agent treatment, so he can't bring it further down.
For the central PA aneurysm is the one that we've seen either idiopathic or not associated with very severe PH, that's a different bucket, but the ones that we've seen in our centers, we've let them get to 8 or 9 centimeters before we do anything. We've operated on a few who had coronary artery compression. Most of them, their coronary artery origin was a little anomalous, it was a little high, so then it got kinked by the PA, but the other ones, 4 or 5 centimeters, 6 centimeters, we just follow them. It's every few years with an MRI, as long as they don't start growing, and they've done fine.
Okay.
Yeah, so Ada, Sasha, you know, in the pulmonary world, it's not uncommon we get sent kind of unexplained hypoxemia. They have a kind of underwhelming chest CT, PFTs, echo, and maybe they desat on a CPET or something like that. You know, in terms of how far we go to chase shunts, and especially right to left shunts specifically, especially if they're on the smaller side. Let's say you do the bubbles, either it's, you know, it's equivocal or it's small on a bubble study. You do a VQ scan, you kind of look for contrast in the brain, the kidneys. What's your threshold for, you know, in a symptomatic patient with proven hypoxemia, what's your threshold to, you know, go for pulmonary vein sampling and kind of really kind of chase that further versus, are those non-invasive tests good enough? Is it, if they're not that hypoxemic, the shunt can't be that big? Walk me through your workflow for dealing with those trickier folks.
Yeah, I'll talk about it from the standpoint of pulmonary AVMs. I think I don't know a great way to understand why some patients with HHT DSAT with like 2 visible AVMs and really nothing else, and then other people who have high-grade shunts by echo and have a normal SAT. Like that patient that I presented at the end of my talk continues to have grade 3 shunting, presumably through microvascular AVMs, and her SAT's 100%. And I have another young woman who had 2 AVMs that were identified who had a SAT in the 80s, and both of them were closed, and now she's SATing 100%. And I just don't understand why some people are hypoxic with this disease and some people aren't. I think from the standpoint of pulmonary AVMs, you know, I think if there's no other explanation for hypoxemia and or your AVMs meet size criteria, really your algorithm puts you in the direction of closing them regardless of if your patient's hypoxic or not, to prevent some of these downstream complications. From the pulmonary AVM standpoint of things, that usually ends up being kind of the end game for patients, regardless of their hypoxemia.
I'd say from a cardiac point of view, I really think that intracardiac imaging at the time of a right heart cath can be quite helpful to see if the previous tests weren't wrong. Sometimes the upper extremity injections might, if someone has a really big eustachian valve, for example, they might have a lot more right to left shunting from the IVC blood that gets funneled through a PFO or something like that. And the upper extremity injections by echo may not be that impressive. And so either doing a lower extremity injection or doing intracardiac echo to really see what the atrial septum and the PFO look like. And it also depends on how bothered the patient is. If they're not that bothered with their slightly low SATs, then I wouldn't go crazy. But otherwise, it can be helpful to have an idea whether this is intrapulmonary or intracardiac.
Sure. And when do you find the pulmonary vein sampling to be most helpful or necessary?
I think that's when we really don't know if it's intrapulmonary shunting or if it's pulmonary disease. Like, let's say they have a little COPD or they have some abnormality in their parenchyma, and we think it might be that, or it might be an intrapulmonary AVM. Then we can sample all 4 pulmonary veins and see if there's one that's specifically lower, then that might give a clue that there's something going on there. Acknowledging that the VQ matching when someone's standing up, when someone's lying down on the cath lab table, a little bit of sleep with a little bit of sleep apnea is probably different anyway, so the baseline conditions are a little funky. And so I think the really impressive differences are just in a small number of people. More often than not, it's people who we think shunt a lot through a PFO, but maybe they have some lung disease. We prove that the pulmonary vein saturation is totally normal. Now we think, okay, it's all the PFO. Let's close it and see how you feel.
But for your run-of-the-mill shunt fraction calculations, it's not something that you're necessarily thinking about. Thanks.
Great discussion. My question's back to Dr. Joseph for invasive CPET. You're talking about extraction defects and fibromyalgia and this category of patients, which we're seeing a lot of with long COVID also. And so I want to sort of reapproach the whole FIC debate that's going on with regard to peak evaluation of peak VO2. So say you have a patient who exerted themselves, their RER is 1.1, whatever, it's peak exercise, their VO2 is low, cardiac output low, extractions high, that's a no-brainer, right? That's cardiac. Okay, take the converse, VO2 is low, extraction is poor, cardiac output's high, that's an extraction issue. It could be a myopathy, whatever. But here's the problem is when the cardiac output is low and the extraction's off, right? There's dependency of those two variables. And my understanding is that if we are to evaluate those two independently, which there is a theory that could be done in normals if they reach peak exercise, that we could apply that rationale, but I'm not so sure that's the case. What's your approach to systematically looking at things when both the output's low and the extraction's off? Because that's really common, especially, for example, in HFpEF patients.
I don't know. No, I struggle with that same thing. I mean, I think that I agree with you. The cardiac output and those variables are dependent on each other. And I don't think, I'm curious what this theoretical independence or like how we can tease those out, but I don't have an answer for you. I look at them, I think I look at the mixed venous SAT of 40%, and I think that's really abnormal, and I'm going to call it that way. If it's in that middle category of like 30 to 40, and the cardiac outputs 70 to 80% are predicted, I'm at a loss, to be honest.
Extraction's low. Yeah.
Oh, extraction's low.
Yeah.
Oh, sorry.
If
extraction's low, you mean like their mixed venous SAT is high?
Is high, yeah. Yeah. So in some ways, right, do you have a combined defect? Is there a skeletal muscle issue and a cardiac issue? But there's dependency among those two variables, right? So when they're both off. How do you approach that?
You have to have shunting somewhere, and presumably they're also hyperventilating.
Correct, right.
I'm speaking
You're talking
in
about the
general,
cardiac
though,
output
not
being
necessarily,
lower.
these the CFS ME patients or whatever, but yeah.
Because if the cardiac output is reduced, or, there has to be a separate cardiac limit. But
Yeah,
other things
sure.
have to be going on. And it's either going to be vascular, shunting, plus minus the mitochondria, but then the question also is how much impact is hyperventilation.
I knew you'd say that.
One last question over here.
Thanks for the talk. I understand most people in this room are physicians, but I really have a mechanistic question. As mentioned by Alexandra, aneurysm is often associated with mutations in TGA-beta pathway. But I never understand the directionality. So are we supposed to activate TGA-beta pathway or inhibiting TGA-beta pathway for aneurysm? Do anyone know?
Well, I mean, as we know, the kind of downstream effects of sotatercept seem to be telangiectasia development.
Right.
So presumably kind of blocking that
Blocking
pathway
yeah.
is going to enhance.
It's gonna exacerbate, yeah.
It's going to exacerbate angiogenesis. I don't want to avoid Dr. Waxman's earlier question about anti-angiogenic therapy for AVMs. I'm not sure that I have a super comprehensive answer for that, particularly outside of HHT. In HHT, the anti-angiogenic therapy certainly decreases epistaxis significantly for patients and improves their quality of life, raises their hemoglobin, and makes them in a less high cardiac output state, and probably impacts things like GI bleeding from telangiectasias and liver AVMs, and kind of improves cardiac output issues from that standpoint. I am not aware that it causes any regression of existing pulmonary AVMs, so the approach to treating pulmonary AVMs, at least in HHT, remains the same, that they should be embolized. What I don't know, I'm actually just not sure if that data is out there or if it's just too soon to know, is if these therapies prevent AVMs from proliferating later down the line in the disease course of HHT. For non-HHT associated pulmonary AVMs, there's just like nothing out there in terms of why these form, if these are like HHT adjacent type mutations that we just don't have, profiled well, and whether some of these therapies would be effective.
There are some people who treat them off-label with avastatin to see if it makes a difference, but, counting the side effects of avastatin and everything else, I don't know that you'd ever get a clinical trial done or get enough patients to do a clinical trial with this stuff.
But you can use thalidomide or
Thalidomide's another one that's been used.
tamoxifen, and side effects in those are pretty minimal. So,
But you're not, again, it's strictly gonna be case
Yeah,
reports
small
or
off-label.
small series off-label.
okay. Well, on that note, I just want to thank everybody, especially the organizers and the folks from North American Thrombosis Forum. Please make sure you fill out your survey there. And also, again, if you're going to be claiming CME, make sure that you do it. And otherwise, thanks very much. Also, feel free to send us any comments or suggestions for the next one, because a lot of the topics from today's and yesterday's came from questions that came up on the last time we did this. So, thanks.